Good afternoon, everyone. I'm Mrs. D. Shobia, moderator of this webinar. I will be working along with you all throughout this webinar. First of all, I would like to thank our God Almighty for His countless blessings. On behalf of Sri Abhirami College of Nursing, we are very much happy to release this 8th webinar. At the same time, I would like to thank our management, board of directors, technical people, listeners, learners, and people on and off the screen for your endless support. The agenda for the day is welcome address, topic introduction, presentation, question and answer, and vote of thanks. Dear viewers, if you have any queries regarding this topic, you can write them in comment box. At the end of the session, all your questions will be clarified. So here we have our principal ma'am, Dr. Johnsy Helena as a convener, and Dr. Irene Mercy, Vice Principal of Sri Abhirami College of Nursing as a coordinator, will be along with us throughout this webinar. Nursing is an art, and if it is to be made an art, it requires exclusive devotion, as hard a preparation as any painter's or sculptor's work. For what is the having to do with dead canvas or dead marble, compared with having to do with the living body, the temple of God's Spirit? It is one of the fine arts. I had almost said the finest of fine arts. This was said by Florence Nightingale. As a nurse, we have the opportunity to heal the heart, mind, soul, and body of our patients, their families, and themselves. They may forget your name, but they will never forget how you made them feel. Rejoice in your work. To do what nobody else will do, a way that nobody else can do, in spite of all we go through. That is to be a nurse. So, to know more about nurses in the clinical setting, here we have our beloved madam, Dr. Shyla Issac, Department of Nursing, Oxford University Hospital, United Kingdom, and we are very much happy to say that she was our former principal, and she is going to present the topic on clinical updates for nurses. We welcome you, ma'am. Now, I invite Dr. Irene Mercy, Vice Principal of Sri Abhirami College of Nursing, to introduce the speaker.
Thank you, Shobya. Good evening to one and all. Very warm greetings from Sri Abhirami College of Nursing. First of all, my praise and I thank God Almighty for His guidance, support, and encouragement. It's my pleasure and my privilege to introduce today's speaker, a dynamic personality, a brave lady, a good leader, a good decision maker, a good administrator, and above all, a backbone of Sri Abhinami College of Nursing and our beloved previous principal, Dr. Shyla Issac Madam. Madam holds a doctorate degree in nursing from Dr. MGR Medical University, Chennai. Madam is having more than 18 years of experience in teaching as well as in administration. Madam has served in various administrative roles as head of department, principal of nursing colleges. Also, she served as examiner, chief superintendent for examinations, inspector by Dr. MGR Medical University and Tamil Nadu Nurses Midwives Council, Chennai. And also, one man committee member appointed by Rajiv Gandhi University of Health Sciences, Bangalore. Madam is also active member of Trained Nurses Association of India. She is an active researcher, guide, and she has published various articles too. Madam has awarded with her general proficiency a best performer during her career. She is also awarded with best efficiency by Sri Abhirami College of Nursing. Currently, Madam is holding a working in Department of Nursing, Oxford University Hospitals, United Kingdom. Now, I am very happy to welcome dear Madam Dr. Shyla Issac to take over the session. Thank you, Madam, for being accepting our invitation for today's webinar. Thank you, Madam. We are welcome you for take over the session.
Thank you, ma'am, for your brief introduction. So, without further delay, I hand over the session to ma'am. Ma'am, now the time is yours.
Thank you very much. Thank you so much for all your elaborate intro. Actually, I'm so thrilled and excited to be present down here because this platform is not new to me. Though the mode of communication is new, probably I wish that the group of audience is very familiar to me. Even you know me and I know you all. And I, first of all, I place on record, I thank my Almighty for giving me this opportunity to share my views in this webinar. I take this opportunity to thank and also I place on record my sincere respect, my regards to our chairman, sir, Dr. Kundavi Devi, ma'am, Dr. Sendil, sir, Dr. Balamurugan, sir, Dr. Uma Devi, Dr. Sucharita, for giving me such a good opportunity to be with you all. And I also thank the other members of the Sri Abhirami College of Nursing, Dr. Jansi, principal, Dr. Irene Mercy, the vice principal, and all my faculty, my students. So I really I don't feel something strange over here because this is a very familiar platform for me, and I really am excited and thrilled to be present down here, and really I feel at home. So without further delay, I think I can jump into the topic. Yeah, I'm going to share the screen with you. Is it visible?
Yes, ma'am.
Yes, ma'am.
Okay. So the topic which I've chosen for today's discussion is uh, common clinical issues faced by nurses. Because every day-to-day life, we nurses are facing with a lot of clinical issues, trials. And because of the hectic schedule of the nurses, we sometimes end up with doing certain errors. So, what I've thought is there are a lot of errors that are committed, not only from the nursing side, from the group, from the medical team itself, from the paramedical professionals, that we commit a lot of errors that may endanger the patient's life. So, as of now, I have chosen the top deadliest nursing errors, out of which I've chosen only five common errors that I feel that are the ones to be discussed. And the good news is that though there are lots of errors that can be committed, but those errors are preventable. And especially if we take necessary precautions, those errors are preventable and we can save the patient's life. The following are the top deadliest errors that I've chosen with. The first one is deterioration of patient condition, not assessed and not addressed. That we call it as RAID, that is recognizing acutely ill and deteriorating patients. And the second one, which I have chosen as pressure ulcers and falls. This is also again a common topic, common error. And the third one is medication error. Fourthly, infection. And next is documentation error. So let's discuss one after the other. The first one is RAID, recognizing the acutely ill and deteriorating patient. So why this is more important is at times we don't feel the necessity to identify that the patient is deteriorating. The clinical deterioration is not being identified. So what I feel is assessment and prompt interventions are the cornerstone for quality and patient care. Because we always talk about quality care, patient safe patient care, whereas sometimes in some aspects we lack our interventions. So assessment and prompt interventions are the cornerstone for quality and safe patient care. To our surprise, the national patient safety agencies They have reported that in the analysis that they have done out of 576 deaths, they identified that 11 percentage were as a result of deterioration, that is, the clinical deterioration, is not identified or acted upon. So 11% means, just calculate, you will get around 63 deaths. So imagine, out of 576 deaths, 63 deaths could have been prevented. The deaths had occurred because the deterioration were not identified, were not acted upon. So the following points why the process had failed were identified. One is not taking proper observations, not recognizing early signs of deterioration, not communicating the observations causing concern, and not responding to these appropriately. So, to put it in a nutshell, these three themes have been identified, like no observations made for a prolonged period of time. At times, what we do is, because of the busy schedule, sometimes we find nurses, they just record the same observations that was done in the morning. They do the same observations. They record the same observations even without doing it. They record it for the second time also. Might be the patient would be deteriorating. That's not identified. So observations were not made for a prolonged period of time, and hence the changes in the patient's vital signs are not identified. So that is one reason. The second reason is no recognition of the importance of the deterioration. So, okay, you have taken the observations, you have recorded the observations, but you don't feel the necessity that you have to identify that the patient is deteriorating. So you're not recognizing the importance of deterioration. Maybe you find that the patient's blood pressure is dropping. You find the blood pressure of the patient is 80/60. Okay, you just record it and then you just go ahead. But recognition of the importance of deterioration is very important. When it is deviating from normal, it should clue you, it should give you an intuition that immediately the action should be taken upon. And thirdly, delay in the patient receiving medical attention. Okay, so you have identified, you have detected, everything is done, but still the medical attention is not given immediately. So even when the deterioration has been detected and recognized, but the patient is not receiving the medical attention immediately. So these are the main three themes that has been identified for deterioration in the patient's condition. Okay, so we have to know when these clinical deterioration can happen. It can happen at any point in a patient's illness. It can happen during the care process. It can happen during an emergency admission to the hospital, that is when the patient is getting admitted to the hospital. It could happen after a surgery, or it could happen after, that is during recovery from a critical illness, or during recovery after surgery. So it can happen anytime during the course of patient's illness. And the good news here is, fortunately, the signs of deterioration during the first 24 hours before the cardiac arrest could happen are seen. So if the patient is undergoing a cardiac arrest, before 24 hours itself, it gives us a clue. Through the observations, we can identify that the patient is showing some signs of deterioration. So it could be easily identified, and when it is identified, it could be easily prevented. So early identification of clinical deterioration is very important in order to arrest, or in order to prevent, in order to avoid cardiac arrest. It has been estimated that approximately around 23,000 in-hospital cardiac arrests in the UK could be avoided each year with better care. See the statistics. 23,000 cardiac arrests in UK could be avoided each year. How we can avoid? Just with better care. So if this is the situation, if this is the statistics in such a developed country, we have to think of how much will be the statistics in India? So we are responsible for preventing certain deaths by early identification. It's in our hands. It is in the nurse's hands. It is in the doctor's hands to identify the clinical deterioration, because nurses are the ones who are with the patients always 24 hours, always they are with the patients. So you can easily identify if the clinical deterioration is happening. Okay, how we can identify the clinical deterioration? By basic, simple, closely monitoring the changes in the physiological observations. So, if you are identifying the clinical observation, the physiological observations, if you're closely monitoring the changes, you can easily identify it. And early identification is very important as to reduce the mortality, to avoid morbidity, and to reduce the length of stay of patients in the hospital and associated healthcare costs. Because here in UK, the healthcare cost has been borne by the government. So, in order to reduce the associated healthcare costs, it is important that we closely monitor the changes and identify the clinical deterioration earlier, because it's not going to cost you much. Just an identification, just a routine physiological observation, that will give you a greater clue. So, as a minimum, the following physiological observations are recorded at the initial assessment when your patient is getting admitted. Right from there, you start your assessment. So, what all you will routinely monitor is that heart rate, respiratory rate, systolic blood pressure, systolic and diastolic, and level of consciousness, and oxygen saturation and temperature. So these are the basic assessments, basic observations that you do for the patient. So this is the vital signs monitor that we use here. So here itself we can see that it's been recorded, like the blood pressure, saturation, pulse rate, then temperature. It is easily recorded, and it is attached here. Everything is maintained in the electronic patient record. So when you are doing the vital signs, it's all in one. Like, you don't have to bring separate thermometer, you don't have to bring separate blood pressure monitor. So everything is attached over here, including the saturation. So you can easily identify. And when you are doing it, and whenever you are doing any procedure or any interventions to the patient, everything is recorded automatically to the EPR. That is, you are attached with a scanner. So when you're doing the clinical monitoring, when you're doing the vital signs monitoring, you have the scanner. So you scan the patient's ID band. Patient has wristband with the name, the patient's date of birth, and you have the barcode over there. So when you are scanning the barcode, automatically it will direct you to the patient's electronic monitor, patient record. So when you're monitoring these changes, immediately that enters into the patient record. And secondly, AUT, A to E approach. So airway, breathing, circulation, disability, and exposure. These are all not new to you, but still, though we know everything, we neglect certain things. We just omit doing it. So that is why I'm just enforcing that these are the assessments that to be concentrated and done. So under A to E assessment, A for airway, B for breathing, C for circulation, D for disability, and E for exposure. What all you will assess? First is airway. So you know that airway obstruction is an emergency. Try to get expert help immediately. If you identify that the patient's airway is obstructed, immediately you should escalate it to the medical team immediately. And any cause of, you know, that any cause of untreated airway obstruction, that could lead to hypoxia, and because of that, that will damage the brain, heart, kidney, and it will lead to cardiac arrest and death. So always look for the signs of airway obstruction. Could be there could be a tongue fall that may cause airway obstruction, or secretions that could cause airway obstruction. So treat it as an emergency and give oxygen at high concentration. In case of acute respiratory failure, aim to maintain the oxygen saturation at 94 to 98 percentage. And if you suspect that the patients are at risk of hypercapnic respiratory failure, like in case of COPD, aim for an oxygen saturation 88 to 92 percentage. And then comes breathing. Always look, listen, and feel for the signs of respiratory distress. So, if the patient is whether the patient is having sweating, or you observe central cyanosis, if the patient is using accessory muscles for respiration, so that shows that the patient is having a labored breathing. And see that the respiratory rate, the depth and rhythm of respiration, everything is within normal limits. And you know that the normal rate of respiration is 12 to 20. And if it is beyond this rate, so immediately you should know that the patient is the patient's condition is deteriorating. It might deteriorate suddenly. So identify it earlier and escalate the concerns. C is circulation. So, what you will observe in the circulation? Look at the color of the hand syncytials of the patients, whether they are blue or pink. That will give you a clue whether the circulation is good. And then assess the limb temperature. You can just touch the patient's hands and feel whether it's cool or warm. And measure the capillary refill time. Just elevate the fingertips to the heart level and give pressure for 5 seconds and let it refill within 2 seconds. 2 seconds. That is the normal refill rate time. And then measure the patient's blood pressure. If you find that the patient's blood pressure is low, the low diastolic pressure, it gives you a clue, it gives you a suggestion that the patient might end up with an anaphylactic or septic shock. Or the pulse pressure is narrowed. You know, the pulse pressure is difference between systolic and diastolic pressure. So normally the systolic and diastolic pressure, that is the difference is 35 to 45. So if you're finding it to be narrowed, then it suggests you that the patient is could end up with cardiogenic shock or hypovolemic shock. And then under the circulation, look for the conscious level of the patients and observe for any external hemorrhage, probably from a wound, from an orifice, or from the drains, even from the surgical wound. You can observe that whether there is any external hemorrhage or any oozing present over. So these are the things that you will observe under circulation. Then comes disability. What do you assess in disability? That is the level of patient's consciousness. We always use the AVPU method. So, under as I said about the patient monitoring, the vital signs monitoring, in that itself, it comes along with the consciousness, alertness of the patient. You will monitor, and that also will be entered into the EPR. So, AVPU method: A is for alert, B for voice, P for pain, and U for unresponsiveness. So check whether your patient is alert, whether the patient is alert and orientated, or if he is disorientated, record it. And then whether the patient is responding to your vocal stimuli, whether the patient is responding to painful stimuli, or the patient is unresponsive. So assess for the conscious level. And alternatively, you can use the Glasgow Coma scale also. And then under disability, you should also see that the conscious level of the patient might be altered due to hypoglycemia. So in every instance, try to rule out whether the patient is going into hypoglycemia. Measure the blood glucose levels. And E for exposure. Okay, you want to do a to E assessment. And thoroughly, when you are doing the assessment, you may have to expose your patient. So try to maintain the dignity of the patient, because you may have to expose the body of the patient for your assessment, and respect the patient's dignity and try to also minimize heat loss. And while you are exposing the patient, try to assess the skin for any rashes or bleeding or any swelling from the wounds, and you assess the wounds for any discharge present or if the dressing is wet. So those things you have to assess while you are assessing the skin. And then the tubings, attachments, probably it's attached to the ventilator or the stomas, and all the tubings like indwelling catheter, the IV lines, everything to be assessed for its proper functioning. And then the temperature of the patient under exposure. Then, how do you monitor this? So here in Oxford University Hospitals, that we do a track and trigger system. So track and trigger system is where, like as I said, as I showed the picture of the vital signs monitor. So as you enter the vitals into the EPR, that immediately give you a trigger. For example, if the normal score is 0, if the score is beyond 1, it will give you a trigger, it will give you a clue that it will alert you that the patient's some physiological observation is not all right. So if it is 1, if it is more than 2, 1 to 2, then you have to periodically assess it, monitor repeatedly. For example, if the score is 2, you may have to monitor the patient every 2 to 4 hourly in order to exclude it, in order to detect whether the changes are going on. And you have to immediately escalate to the doctors. And moreover, when you are recording it, automatically that goes to the EPR, and that will alert the concerned medical person also. So the physiological observations, normally it should be maintained at least every 12 hours, but the frequency of monitoring should increase according to the level, according to the condition of the patient. So if you're identifying some abnormal physiology, then the frequency of monitoring should increase. And in other clinical circumstances, like additional monitoring should be done, like for example, hourly urine output or blood glucose, biochemical analysis such as lactate. So these assessments, according to the patient's condition, to be monitored. And secondly, risk assessment. So this risk assessment, I think we are mostly negligent of doing it, because here the routine of doing is why I'm emphasizing, why I'm telling about the clinical concerns in UK, especially in Oxford University hospitals, is there that are all like the practical concerns are very good. So we also could adapt such concerns so that our care also will be developed, because we have a real good team of doctors and nurses for a better care of patients. And if these things are also included, that will definitely take us to heights. So under this risk assessment, usually when the patient is admitted, within the 6 hours of admission, you do a lot of assessments. Here we have a lot of assessments, risk assessments to be done. Like you have the skin assessment, that's called a Braden assessment is there. And then must assessment, that is malnutrition universal scoring test, that shows the nutrition status of the patient. And then false assessment, mobility devices using assessment, like manual handling assessment. Then the status of the patient, the total assessments of the patient. So there are a lot of risk assessments to be done within the 6 hours of patient's admission. Even the pressure sole assessment, all these are there. So I'm going to deal with skin assessment and false assessment. So skin assessment is very important in order to prevent pressure ulcers, because usually prevention of pressure ulcers, that depends mostly on regular observation and taking preventative action. Because if a patient develops pressure ulcer, that shows the negligence of nursing care, that we all know. So we have to be very careful in preventing pressure ulcer. Regularly you have to observe at least once in a shift. One time in a shift, you have to observe the patient's skin condition for pressure ulcers and take preventative action. So there is a model adopted for pressure sore prevention, that is an SKIN 5-step model. So I would like to elaborate on that. It is S is for surface, then again the second S is for skin inspection, then K for keep your patients moving, I for incontinence and moisture, and N for nutrition and hydration. So, you know that pressure ulcers are caused due to pressure over the particular pressure areas, or the friction, moisture. These are all cause pressure ulcer for the patient. And so, make sure that the patient's surface has the right support. Probably, even if the bed is wrinkled and you have a lot of wrinkles over the bed, that could even cause pressure over the patient's skin, and that could lead to pressure ulcer. So make sure that the patient's bed is flat and it is well supported, and you need to see that the patient needs any nimbus bed or air cushions, air beds. So accordingly, you should provide for the patient. And then the skin inspection. So early inspection means early detection. So as I said, at least once in a shift, you have to do the skin inspection regularly, because sometimes what happens is the on admission the one nurse would have written that the patient's skin is intact, and even that is again you are legally responsible. On admission itself, a patient might have some pressure ulcer or might be prone to develop some pressure ulcer that would have not been identified and recorded. So what you do is you just keep writing saying that the patient's skin is intact, but see that you are responsible for that. Maybe later on someone identifies the patient's skin has pressure ulcer, so you are held responsible. So always see that you inspect the skin right from the admission of the patient, and then keep your patients moving. If your patients are bedridden also, you have to see that you're changing the position of the patient frequently. At least 1 to 2 hourly the patient's position should be changed, and see that the feet is not pressing over some even the bed, or you are not pressing against any equipments. So see, observe the patient's surrounding and make the patients moving frequently on bed. And then is incontinence and moisture. So this is again mostly pressure. So pressure ulcers are developed in bedbound patients. So when you find that the patient has incontinence, see that you change the patient's pad frequently, because the moisture caused due to incontinence, that will definitely cause skin erosions and lead to pressure ulcers. So your patients need to be kept clean and dry always. And then nutrition and hydration. You know that nutrition helps your skin to maintain its moisture and elasticity. So help the patients to take the right diet and plenty of fluids. And here we always get the help from tissue viability nurse. So they are specialized in skin care. So they are good in guiding you to prevent pressure ulcers. So as I said, once you assess the patient's skin condition, and if you suspect that there is discoloration or hardening of skin, or there is some oozing present, or there is skin erosions, immediately you have to give the notice to the tissue viability nurse and make her to assess the patient's condition, and further treatment could be promoted to avoid skin deterioration, that is the pressure ulcer. And secondly, false assessment. As you know, false assessment is common among old aged above 65 years, and according to CDC, 1 out of 3 adults aged over 65 fall each year. How sad it is, because this is easily preventable. If you see to the risk of falling, it's not one cause, it's multifactorial. So there are a lot of risk factors, like it is said that a history of falls is one of the strongest risk factors for a fall. Repeatedly, a patient falling because of his gait disturbance or some disease conditions, a history of falls is a strong risk factor. And then the other conditions like arthritis, diabetes, incontinence, stroke, Parkinson's, then muscle weakness, visual and cognitive impairment, depression, and certain drugs, because these are all certain disabilities. This is like a additional package given as the patient as we age, as we go get older. These are all like as a complementary package, that's all given. So you should assess what are the conditions, what are the risk factors for the patients, and try to prevent falls. So it's found that 40 to 60 percentage of falls are resulting in major lacerations and trauma, brain injuries or fractures. So, and even the complications, due to falls, the patients end up with distress, pain, loss of confidence, the quality of life is affected, and their independence is affected, and it causes mortality. Okay, so how do you prevent falls? First is a multifactorial risk assessment should be done by skilled professionals. So, like an occupational therapist or a physiotherapist, they have to do a risk assessment. And apart from that, a clinician also should be doing the risk assessment for the patients, as we discussed about the various risk assessments, risk factors that need to be ruled out, and use of appropriate mobility devices. So once you identify the factors that are causing risk, then you need to find out what is the appropriate mobility device for your patient, like a walking stick or a Zimmer frame or any other kind of mobility device. And then use of sliding sheets and appropriate hoists for bedbound patients. Because normally for bedbound patients, we just pull and push. That should never be done. Don't ever use the sheet of the patient to pull and push the patient, because that itself will cause skin erosions. So these are some of the hoists that we normally use here. This is very easily used, and even the nurses can their manual handling also could be improved a lot. This first one is usually it is used for bedbound patients, because it has a sling, and a patient can be easily like a sling that from the bed, or you want to put the patient to the chair, you just move the patient from the bed to chair very easily, and you can make the bed easily, and patients are also moved out of bed, not lying down on the bed for a long period of time. And here I've seen a lot of patients who even come as bedbound patients, they go walking. So because of the prompt exercises and prompt physiotherapies that been administered, that's been given to the patients are made so well. And again, this second and this the third ones, these are all for patients who can somewhat stand, but though the gait might be disturbed. So those patients can have the handle, they can hold on the handle, and they can be easily moved on to. So these are various hoists used here. And this is sliding sheet and pad. So this is very cost effective. This is not going to cost much. This is just like a plastic sheet, but very slithery type. This is easily put under the patient, and you can move the patient up or down without giving any harm to the patient. And this one is the pad slide, that from the patient's bed to the other stretcher or any operation table that you are changing, it can be easily changed by using the on top of the path slide. You put the sliding sheet, and when you pull the sliding sheet, the patient is moved to the other device. And then you make sure that you make the patients to ask for help, because patients, okay, it's good that the patients need to be independent, but still if they need help, you should encourage them to ask, because they might feel bad to ask for help. And make sure that there are no obstacles around the bed, and see that the patients can move around easily to the restroom or around the bed, and observe for the patient's gait when they are out of bed. See that hourly rounding is done, because when you do an hourly rounding, you can just check whether the patient needs any assistance for toileting, or even you can see that the objects are within reach of the patient, and the patient is able to take food, and asking about pain. So you can make that time useful for checking, assessing the patient's condition. And use protective measures always. So always see that the patients, when they are walking around, so see that they are not walking with bare feet, because they might slip over. So here we use grip socks that has grip over, and the patient can easily walk without slipping over. And see that the bed alarms, that is the bedside call bells, are given, is at the reach of the patient, in order to decrease the risk of falls, because the patient can easily get your help. And thirdly, medication errors. This is again a very common error that is committed by the nurses. So we have to be very careful in avoiding medication errors. So according to National Medication Errors Reporting Program, medication errors kill one person every day in US. So just imagine the rate. One person a day, if it is killing. So we have to be very careful to avoid this medication error. So how we can avoid medication error? Always remember the five rights of medication administration. Always we say about the five rights: right medication, right patient, right dose, right time, right route. We just tell it, we know it, but still we may not adapt it, we may not follow it at times. So always see that you follow the five rights and avoid distraction. So that's why here in a hospital they have separate medication room, so it can be accessed only by the nurses. You have a separate code for that. So this is done in order to avoid distraction, because if it is commonly kept and you will talk with others, or many things might distract you, so that you will not be able to concentrate on the medication. So avoid distraction. And if you have any doubt, don't feel bad to clarify it. Use your thing of clarification. You can ask, you can clarify with your seniors or anyone, and you can double check any medication that's to be given before administering it, especially when you are giving antibiotics or any kind of high alert medications. You have to double check it before giving. Like insulin, you have to double check before giving. And utilize a barcoding medication scanning system. As I told you before, that barcoding scanning system, when you are scanning the patient's wristband, automatically that will direct you to the patient's APR. So you will not be able to take the medication to the patient and give. You have to go with the computer to the patient. Always, only then you can administer the medication, only then it will open for you. So you scan the patient's wristband, and then you can open the medication administration slot. And there, when for example, if you are administering an antibiotic which is due for 12 o'clock and you are giving by 2 o'clock, so that itself will ask you why there is a delay. So only when you answer for the delay, you will be able to administer that particular medication. It cannot exist that. So like utilizing this barcoding system is really a very, very important and a very effective method of preventing medication errors, because that will not allow you to enter into the patient system. So and if you make mistakes, and automatically you'll be the incident report would be occurring on your name. So see that this is a very good method of scanning. And take an active role in consulting with the interdisciplinary team. If you have any doubts, you can ask the pharmacy to find out what could be done. And also in the EPR itself, in the system itself, you have the access to Medusa, something we follow in Oxford University hospitals, that gives you the thorough information about the medication, how you have to administer, what is the route of it, what is the dose of it. Everything is clearly given in the Medusa, so easily you can access it. And then ensure that all lookalike sound like medication, like amitriptyline, aminophylline, atenolol. You have list of medications that look alike or sound alike. So that need to be stored separately apart. And then double check all high alert medications. For example, if you are giving heparin more than 5,000 IU, you have to double check it. And only if you get a signature, get a sign from an other colleague, only then you will be able to administer such medications. Otherwise the EPR will not allow you to enter. So these are all certain methods that you can adapt to avoid medication errors. And then understand and know the medications before giving. Know the action and adverse reactions. Here the patients are very, very wise, and they are aware of all the medications that they are taking. And before receiving, they will ask you what is the action of the medication, what is the side effects of the medication. So and it's also good enough to avoid medication errors. So tell each patient what the patient is getting, what is the action of the medication, why they are receiving it, and what are the side effects that they could develop. And after getting their consent, you might give the medication. And as I said, if you have any doubts, you can check with the drug guides also. Here we follow BNF, British National Formulary. So that gives you, like how we use SIMS. So that gives you an idea of what is the medication, what are the action, road side effects, everything. So, and then the other important thing is keep in mind that even if your doctor has ordered sometimes a wrong medication, the nurses are still remaining culpable, because you are held responsible for the action. You are responsible for administering wrong medication. Sometimes, if the patient's, for example, I'm telling, if the patient's weight is 35 kilograms, and the doctor has ordered prescribed for 1,000 milligram of paracetamol, which shouldn't be given if the patient's weight is below 50. So if the weight is below 50, you can administer only 500 milligram of paracetamol. So likewise, you should be knowledgeable. You should also see that even if it is ordered, sometimes they would have ordered without checking with the weight of the patient. So you should be careful before administering any kind of drug. Then, fourthly, it is infection. Again, this is again a very, very common mistake that we commit. Not a mistake, I can say, that sometimes unintentionally it is done. Not only the nurses, like healthcare professionals, we all should be very careful of avoiding hospital acquired infections, giving hospital acquired infections to your patients. Because patients will come with lot of complications, they come with lot of agony, and you give an additional gift of infection. When the patient leaves, gets additional gift and goes. So that is to be avoided, definitely. So according to the statistics, healthcare associated infection in developed countries, it ranges between 3.5 and 12%. And in low and middle income countries, see the statistics, it is around 5.7 and 19.1%. That means it shows that about 20% among out of 100, they develop infection and go. They get healthcare associated infection and go. So, what are the factors that put patients at risk of infection in healthcare settings? So, they come to you for getting a better care, but we are giving them an additional infection. What are the factors that cause patients to develop infections? A prolonged inappropriate use of invasive devices, because we use a lot of invasive devices and antibiotics, that again is a cause of infection. Then high risk procedures, then setting with limited resources. Though you're giving a very good care, if there are no much resources, probably you don't have proper equipments, and the resources are so limited, so that also would cause, and repeatedly you use the same thing, just to wipe it and use the same equipment for the next patient. So that is again reason for hospital acquired infection. And inadequate environmental hygiene, then waste disposal, then poor infrastructure, then insufficient equipments, as I said, understaffing. Probably understaffing is one of the, because the nurses have no time even to wash their hands. So understaffing is again a cause. Then overcrowding, poor knowledge of infection control measures, and then absence of policies and guidelines. Okay, now how to prevent infections? We always tell that hand hygiene, and now due to COVID we always say that you practice hand hygiene always, not only for nurses, it's for everyone, all even for common people. We ask them to do hand hygiene, hand wash every now and then. So hand hygiene is one of the best practice the nurse should adapt, and it should never be taken for granted, because it's a very important point to prevent infections. So then use of PPEs. This protective measures should be always taken care of, because you also should have the provision of doing hand hygiene in the hospital. Here I can see that every 10 meters you have the hand washing facilities, you have the PPEs, because when you go to the near to the patient itself, before that itself you have to wear it and go. So it becomes an automatic practice. And every 10 meters you have the ppe hub, and where you have small, medium, and large size gloves, and then apron, and you have the hand hygiene, the hand washing facilities everywhere. You have here and there, you can find it. So that itself make us aware. And then also infection audit is done periodically, whether the medical practices, like the healthcare professionals are washing their hands, including like you have an audit. Those the doctors who are coming, the physiotherapists, the other paramedical persons, whoever is coming, and the nurses, everyone is assessed whether they are doing hand hygiene properly. So that is again, audit is a very good practice of in promoting hand hygiene and preventing infection. And when you are doing a procedure, always see that the equipment is disinfected. Even if you are using a tray, when you are setting up a tray, always use it. You wipe it with cleanal wipes before and after use. And remember to always practice aseptic technique, which is been neglected a lot, and use of chlorhexidine for skin preparation, and guidelines to be followed for central line use. And while you are removing the lines, like IV lines or central lines, when you are removing, you have to be very careful. You have to follow the aseptic techniques always to prevent bloodstream infections. And while the patient is in catheter, so appropriately clean the urinary catheters, and see that it's been the long term use is being avoided, because that can cause catheter related infection. Unless medically needed, the patients, the long time use of catheters should be avoided. Then finally, documentation errors. Again, this repeatedly we used to say that documentation, because it will make, if you don't document properly, you are responsible. Keep in mind that if it wasn't written, it never happens. Because where, even if you have given an excellent care to the patient, you have given every care to the patient, but still, if you don't document, it means that you haven't done that. And if your patient contracts an injury during your period, it could reveal that neglect based on lack of if you have not documented it, it shows that you are negligent of it. So always see that the documentation is properly made, and steer clear of documenting errors. That is, accurately document all the major events that occurs. For example, you are identifying that the patient's physiological observations are changed. Like as we said, as we were discussing about in the rate, you find that the patient's blood pressure is reducing, deteriorating, or you immediately document it. If you have not documented that, that you will be held responsible for that. And then monitor the patients regularly and document the interventions performed. Whatever the interventions being done, you have to monitor it and you have to document it properly. Because sometimes what happens is, okay, you found that you have detected the clinical deterioration, and you have intimated, you have escalated to the concerned doctor or the medical team, whoever it is, you have escalated, and the doctor has attended it, and you have to notify what time you have informed the concerned person, and what time the action has been taken, what was taken, everything you have to document in detail, so that you will be protected. And report any adverse events. For example, you are starting a blood transfusion, and you find there are adverse reaction occurring in the patient. Immediately stop it and immediately document it and inform to the nurse manager or your supervisors, and monitor and document the physiological parameters appropriate. As I said, the frequency of monitoring the physiological parameters, that differs. If your patient need to be monitored frequently, so accordingly you monitor it. If you're suggested to monitor the physiological parameters every 2 hours, monitor it and properly enter it in the, and address all the signs and symptoms of distress. If you notice any kind of distress in the patient's condition, if you're finding any new signs and symptoms arising in your patient, immediately you have to document it and raise concern, escalate to the concerned person. And the time and content of all the healthcare provider notifications. Like as I said, if you are informing that to the doctor or to the senior nurse, whatever you're doing, or even as I was discussing about reference with the tissue viability nurse. So if you are noticing anything abnormal on the skin, you have intimated to the tissue viability nurse, and she has assured to visit the patient. Everything you document, and then uh, ensure all this is very important. You do a lot of things, you do everything on the patient, you do all the care, document for a different patient, then that's completely going to destroy everything that you have done. So ensure that all the documentation is made on the right patient, and document even the patient education that you're giving, because once you educate the patient what all you are educating, every points, and even the caregivers education, everything you write in detail, and the progress of the patients. And one thing I had forgotten to tell, right from the admission of the patient, you need to assess the first admission document is very important, because once the patient enters to your care, enters the clinical to your care, see that all the observations are made, and not only making, recording is very very essential. If you find that even if the patient has come walking into the hospital, or the patient was wheeled into the hospital, that also you should mention, whether the patient came walking or wheeled into the by wheelchair or stretcher. Anything, any information has to be promptly recorded and documented, so that our patient care is improved and you improve a better quality and safe patient care. Thank you very much for listening.
Thank you, ma'am. Thank you for your fantastic and remarkable presentation. So, viewers, this is the time to ask your questions. So, viewers, you can ask or post your questions now. So, ma'am is waiting for you, people. Please ask some questions.
I think they have understood everything. So
Yes,
there
ma'am.
is no point. Either they have understood everything, or because this is not a very new topic, this is a common topic, but usually a neglected one. That's why I chose this one.
Okay, ma'am. Thank you, ma'am. And thank you, viewers. Now we have come to the end of the session. I hope this webinar series was very much useful and informative one to update our knowledge in the field of nursing. So thank you all for joining with us for today's webinar. Have a happy ending. Safety, seek safety, aim safety, follow safety, ensure safety, teach safety, and yield safety. So always be safe. Once again, I thank you one and all. Thank you.
Thank you so much. Thank you so much,